Bismillahirrahmanirrahim. Assalamu alaikum. My name is Rabia Ahmed from 4th Prof Morning. My roll number is BP1650179 and I belong to group number 27. The chapter assigned to my group is drug-induced pulmonary disorder. There are a number of drug-induced pulmonary disorders. I will be covering gemcitabine-induced pulmonary toxicity. First of all, I want to discuss about what is gemcitabine. Gemcitabine is a pyrimidine analog and used to treat cancers, pancreatic, urothelial, breast and ovarian cancer. Pulmonary toxicities due to gemcitabine have been reported. Risk factors related to gemcitabine. Patients that appears to be more prone to developing pulmonary symptoms including men, age older than 65, smokers and people taking adjuvant therapy. Side effects. The following side effects are common, occurring in more than 30% for patients taking gemcitabine. Nausea and vomiting, fever within 6 to 12 hours of first dose, rashes. Myelosuppression is the most common dose-limiting toxicity. Mechanism of action. The exact mechanism is unknown. Cytarabine, another pyrimidine analog, has been known to cause a syndrome of non-cardiogenic pulmonary edema in 13 to 28% of patients and develops after treatment when conventional and high-dose regimens. Histopathological studies of these patients show interstitial and intra-alveolar proteinaceous edema consistent with ARDS. It is postulated that damage to the capillary endothelial cells causes the leakage of the fluid resulting in edema. In view of the structural and metabolic similarities between the two drugs, it is likely that they share the same mechanism of pulmonary injury. As you can see, the structure of gemcitabine and cytarabine are same, so they sharing the same mechanism. Management. Gemcitabine-associated pulmonary toxicity is generally self-limiting on discontinuation and is often responsive to glucocorticoids therapy alone or plus a diuretic. Case study related to gemcitabine-induced pulmonary toxicity. A 66-year-old man with NSCLC, non-small cell lung cancer. 1 year previously, he had a right upper lobe wedge resection and radiation therapy. He now presents with large local recurrence and enlarged bilateral mediastinal lymph nodes. Weekly IV gemcitabine treatment is initiated. He receives gemcitabine 1 gram per meter square on days 1, 8 and 15, followed by 2-week rest period. After the second cycle, he presents to the emergency department with complaint of dyspnea on assertion. Physical examination revealed that he has significant peripheral edema and vital signs are notable for an oxygen saturation of 82% on room air. CB has maintained good room air saturation of all times despite a 100-pack air history of smoking and history of RUL wedge resection. A chest radiograph shows increased interstitial markings. CB is admitted to the hospital for further workup of dyspnea. How do patients with gemcitabine-induced pulmonary toxicity usually present? Before starting the soap notes, I want to discuss about chemical presentation. Mild dyspnea occurs in 25% of patients receiving gemcitabine. Severe lung injury, 22 to 42%, was recently reported as dose-limiting toxicity to patients with Hodgkin's disease. Common clinical findings in a review of severe gemcitabine-associated lung injury. Dyspnea 70%, fever 35%, pulmonary infiltrates 22%, cough 19%, respiratory distress 18%, hypoxia 14%. Diagnosis time is 48 days. Now I am going to share soap notes related to our case study. Subjective. Age 66 years old. gender, male, history, 100 pega air smoking, 1 year previously had a right upper lobe wedge resection and radiation therapy. Objective: after second cycle, presents to emergency department with complaints of dyspnea. Physical examination reveals that he has significant peripheral edema. His vital signs are notable for an oxygen saturation. Assessment: dyspnea has been assessed as a result of gemcitabine toxicity leading to interstitial pneumonia. Plan: gemcitabine-induced pulmonary toxicity are mild and self-limiting. CB has maintained good room air saturation of all times. Gemcitabine should be discontinued and CB should be started an oral corticosteroid therapy. Prednisone 40 to 100 mg twice daily and low-dose furosemide 20 to 40 mg. Temporal association is important as ruling out other causes such as infection, metabolic causes, cardiac compromise, lymphangitic spread, and disease progression. All these risk factors including age and smoking history and non-small cell lung cancer treated with radiation therapy. Thank you.